Hey guys, welcome back to another presentation. Today we're going through patellofemoral pain syndrome. Boy, that's a mouthful, isn't it? Also known as runner's knee, so let's dive right in. So to begin with, let's just explain what the patellofemoral joint is. The patellofemoral joint is not the hinge joint of the knee, which is formed between the end of the shin and the end of the thigh bone, that hinge joint, but it's actually more of a saddle joint that's created between the patella or the kneecap and the trochlea or the groove, almost like a valley, if you like, at the end of the thigh bone. And you can see that, let me just highlight it for you here. You can see that just in this area here. I like to use this analogy of the train on the tracks, where the train is the patella and the tracks are that groove, that valley, if you like. Now, first thing to illustrate here is that when we bend and straighten the knee, different portions of the kneecap of that, what we call the retropatellar surface, which is just a fancy way of saying the back surface, undersurface of the kneecap, different parts of that are articulating or coming into contact with the groove. So different parts of the train are coming into contact with the tracks. And you can see that on the little picture on the left here. The first point's 20. If your leg is straight out, your quads, those front thigh muscles are relaxed, you notice you can poke and prod that kneecap around because it's not yet, the train hasn't lowered down into the tracks yet. So there is no articulation, there is no contact area yet. But as you start to bend the knee, the bottom sort of angle here of the kneecap around the 20-degree point starts to come into contact first. And then as we continue to bend the knee, it starts to kind of migrate upwards. So by the time we hit 90 degrees, that 90-degree bend, this is the area that is articulating. This is the part of the train that's in contact with the tracks. Now, you probably look at this slide thinking, this guy's lost his mind. And I wouldn't blame you. But stay with me. What we want when it comes to pressure on the retropatellar surface, the back of the kneecap, is an even spread versus a dollop. Now, what do I mean by that? Well, you just saw that picture highlighting which areas of the kneecap articulate or come into contact with the groove, which parts of the train come into contact with the tracks. We can, via various different means, which I'll go through later, influence and optimize is probably a better word, the spread of the load across a wider surface area of the back of the kneecap. So that's why you want to think about the even spread versus the dollop, and let's go through how we can influence that now. So I wanted to show for you guys, illustrate for you guys with this graph, the effect that activating the quads has on kneecap stability, on patella stability. So just a couple of points to highlight here. Or terms defined. So the retropatellar surface area is just a fancy way of saying, so here we've got the patella, the kneecap, and we've flipped it round, so you're seeing the undersurface of it. That's the retropatellar surface. The knee flexion angle, you can see at the bottom is just how much the knee is bending, and you see that's done in degrees from 0 up to 120. So essentially from lockout down into a full bend. And of course the quad tension highlighted by these, you see you've got the clear white circles when we've got quad tension, on at its highest. And you can see very clearly here that the amount of contact area, there we are. The amount of contact area we've got as far as how much coverage we're getting on the back of the kneecap is much, much higher when we follow this line here when the quads are actually at their highest activation. So if you go back to that analogy of the spreading the toast, spreading the butter on the toast, when we've got the quads going, that's when we've got that nice even spread. And the less the quads are active, we start to get more of that dollop. We're starting to have this less effective spread of the load across the rear surface, the back of the kneecap. So taking this concept of the train on the tracks a little bit further, one step further, we've just mentioned that, again, our goal is to spread the load, to spread the butter evenly as much as we can across the piece of toast versus that dollop. We've just seen that if we have the more active our quads are, the more that's going to help to keep the train firmly rooted in the tracks and spread the load that way. But if you flip that round and think, how can we keep the let me think of how I'm going to put this. How can we keep the actual piece of toast stable? Because imagine you're trying to spread the butter, but the piece of toast is flying all over the place, or the piece of toast is at a certain angle and you're struggling to actually spread it evenly. That's what I mean by thinking of the tracks under the train. And so that piece of toast, sticking with that for a second, even if we just have, you can see in the picture here, an increase of that road. This is internal rotation that's being shown of the femur. You can see that it's going to have a difference. It's going to have an influence rather on how much of that the tracks, the groove, are in contact with the back of the kneecap. And it's, spoiler alert, it's less. Even just 10 degrees of femoral internal rotation, that inwards rotation of the femur or the thigh bone, which is where that groove is, can decrease, the contact area and increase the patellofemoral joint stress by 50%. So a final image just to help you guys visualize this from an MRI bird's eye view, and just to help orientate you. I'm sure you can just tell anyway that here's the train, here are the tracks, here's that groove, here's the train, here are the tracks. And when we start to get this angulation of the femur, this is that internal rotation I was talking about, you can see the drastic difference in contact area that we have. It diminishes. So we've got less tracks, if you like, in contact with the train now. So just to conclude there on the quadriceps is that the reasoning for now that we're going through, that we're using, is one, that with increased quads activation comes better train on the track stability. It's going to help to increase that that contact surface area of the retropatellar surface, and thereby spreading the stress. This is also backed up by a massive amount of research, and I thought it was interesting is that I want to take a little trip through time here, is that spoiler alert, this isn't the first time. We haven't just started developing runner's knee in recent years. People have had it for a long time, and time again, quadriceps strengthening always seems to deliver. You know, we were going back pretty much just to the late 70s through to the 80s with Jenny McConnell, a renowned Australian physio who was a pioneer of advancements in patellofemoral rehab, all the way through to more recent systematic Cochrane reviews, which really place a solid evidence-based stamp when it comes to quadriceps training for this particular condition. So if you haven't watched the video already on the knee shield principles that this slide is from, I'd highly recommend that you do, because everything will make a lot more sense if you've seen that video. But just to briefly recap it here, we spoke about the idea that if we're getting issues going on at the knee locally, a lot of the time, at least in the situations where we've had an absence of a trauma, an absence of a clear mechanism, that our knees end up becoming painful because of issues not going on necessarily at the knee locally, but issues, deficits above or below, at the foot and the ankle below, at the hip, pelvis, trunk, etc. above. And runner's knee and patellofemoral pain syndrome is absolutely no exception to that. When it comes to looking at issues above the knee and this idea of controlling the tracks underneath the train from the top down, there are a couple of key muscles, key motions to consider. One of those motions we've already mentioned is that Ephemeral internal rotation, so that it's a combination really of adduction. So adduction is just the thigh bone coming inwards, and internal rotation you can see highlighted with that red arrow there, that motion. The second movement is this sort of pelvic drop. Now, ideally, you want, if you imagine a spirit level in line with where your belt line would be, when you land on one leg in a single leg scenario, that bubble wants to be kept in the middle. But a lot of times, because of weakness inhibition in these muscles, particularly glute medius, is your sort of primary stabilizer in that frontal plane. And remember, frontal plane is just that sort of side to side type motions, and transverse is the rotational plane. If we end up getting, for whatever reason, weakness or inhibition of those muscles, when it leads to that altered position, altered alignment, and again, like we mentioned in the previous slide, we're getting that dollop versus an even spread. Now, to tie this into some research here, this was a study in the Australian Journal of Physiotherapy in 2009, but you can see that it references others, and this has been reproduced a fair amount of times, that a common finding is weak hip muscles with patients with patellofemoral pain. Now, the key distinction here, though, is that we don't know for sure whether this is causative or compensatory. So whether they had weak glutes, etc., weak hip muscles, and then that led to the pain, or whether these muscles became weak as a result of the pain. Either way, interventions that target these muscles are very effective, and they've proven to be effective many times. So interestingly, a study, this is one of the ones referenced here actually, Ireland et al. 2003, showed that PFP, by the way, stands for patellofemoral pain. Patients showed 26% less hip abductor strength. That's the motion produced by these muscles here, glute medius, glute minimus, compared to age-matched controls. Now, they also showed actually that these patients exhibited 36% less hip external rotation strength compared to these controls as well, and they're using handheld dynamometry to measure that strength. I think what I take from that is that we know we need to train the hip muscles, but in the context of pain or preventing pain with prehab, preventing this type of kneecap pain, rather than just picking any old glute exercises, we need to think specifically think in terms of motions rather than muscles. What motions seem to be linked to the development of this kind of pain? And it seems to be in the frontal plane, this kind of increasing Q angle, this lack of the, for want of a better term, being able to keep the spirit level bubble in the middle. And then this combination of hip adduction, which is just the angulation sort of inwards of that femoral thigh bone, and internal rotation moments. So when those moments start to happen, when those motions rather start to occur, we know that we're starting to get an overload of localized areas of the back of the kneecap rather than that nice even spread on the toast. So I wanted to finish this up by tying it all into an actual exercise. And let's have a look at me doing single leg hip hinge here, single leg deadlift. Now, I want to say that what's most important are the movements that you don't see rather than the ones that you do. What do I mean by that? Sounds very cryptic, doesn't it? What I mean is, if you cast your mind just back to the previous slides there, where we're talking about these motions that are associated with the development of pain emanating from the kneecap, these motions like the pelvic drop, trying to keep the bubble on the spirit level in the middle, that pelvic drop happening when we're generally in a single leg stance scenario, the knee kind of caving in, the thigh rotating inwards, and the muscles that help us to prevent and control those motions are ones such as the glute medius. And this table here is just from an EMG study, so electromyography, where they essentially just stick electrodes on muscles, get people to do certain exercises, and it shows how much those exercises actually activate those target muscles. And you can see that single leg deadlift, is quite highly ranked when it comes to recruitment of glute medius, which is great for our purposes in preventing and controlling, I should say, controlling those motions effectively, helping us to prevent development of pain at the kneecap. A couple of other things this exercise does is that we've spoken about a lot from the top down control of the knee, but from the bottom up, just the fact we're in a single leg scenario in barefoot or in socks in this case is going to help us to get that lovely recruitment through those foot intrinsics, through those muscles that stabilize the arch of the foot, helping to reduce and control these aberrant motions from the bottom up as well. And again, just stabilizing in those two planes that we mentioned before. It recruits the muscles in the sagittal plane. All that means is that when I'm moving up and down, so we've got certain muscles that are preventing unwanted motion from occurring, meaning the caving into the knee, the dropping down the pelvis, etc., etc. But to actually extend my hip and just pull me back up from this deadlift, obviously I'm having to recruit through glute max, through hamstrings, etc. And that's what I mean by recruiting target muscles in the sagittal plane. So we're getting a really great blend of a lot of beneficial factors working from the top down, the bottom up, all with the intention of addressing those aberrant movement patterns that lead to the development of runner's knee or patellofemoral pain syndrome. So I hope you found that useful, guys, and look forward to catching up with you in the next session.